Okay, can everyone hear me good? Okay, great. All right, welcome everyone. I welcome you to today's webinar titled Gestational Diabetes Risk Prevention and Management. My name is Tammy Akintileba. And I'm the coordinator for the Perinatal and Infant Health Program here at the Saskatchewan Prevention Institute. And first of all, I'd like to acknowledge that we are on Treaty 6 territory and the homeland of the Métis people. So before I introduce today's speaker, Dr. Jill Newstead Angel, I would like to just briefly highlight what we do here at the Prevention Institute and within the Perinatal and Infant Health Program for the benefit of those who may not be aware. So the goal of the Perinatal and Infant Health Program, like the name suggests, is just to provide information for healthcare providers and allied healthcare providers and increase their awareness on health issues relating to preconception health, pregnancy, and postnatal health. This program also covers aspects of infant health, early infant health, and our primary stakeholders, like I said, are health and allied health providers, as well as service providers and also the general public. So we do this mainly through primary prevention strategies by providing evidence-based information and resources on topics like gestational diabetes, like we're talking about today. Also on things like oral health in pregnancy, maternal mental health, substance use in pregnancy, domestic violence. Also topics in early infancy like breastfeeding, vaccination and immunization, safe sleep practices, etc. are some of the topics that we cover. So in a nutshell, we'll be increasing awareness on those topics to health and allied health professionals so that they can better support their clients and that women generally can make informed choices throughout their pregnancy, delivery, as well as their child's infancy. And for those who may be interested, I also coordinate what I call the Maternal and Infant Health Interest Group, which is just a forum to share information, resources related to maternal and infant health within the province here in Saskatchewan. There's no commitment in terms of meetings, but we just share information via a Google group. So the information comes to you by email. So if anyone is interested in that, you can reach out to me after the webinar by sending me an email. I'll share my email in the chat box. The Saskatchewan Prevention Institute, it's a provincial organization. It's a non-profit organization with a mission to reduce disabling conditions in children by providing evidence-based information to Saskatchewan providers, families, and communities. And our goal generally is healthy children. I just thought to also mention that. So before I introduce today's speaker, I'll just like you to use the chat box if you have any questions, and our speaker will be able to respond after the presentation. So I'll just introduce Dr. Jill Newstead Angel. I'll just read her profile briefly before I hand over to her. Dr. Newstead Angel received a medical degree at the University of Saskatchewan in 2001. She completed her internal medicine residency in Saskatoon, and she completed a clinical fellowship in obstetric medicine in Rhode Island, US, as part of a 2-year general internal medicine fellowship. Her area of expertise is in medical disorders in pregnancy, with a special interest in diabetes in pregnancy. She is the medical lead for the Diabetes and Pregnancy Program here in Saskatoon, and she also manages hypertension in pregnancy and works closely with her maternal fetal medicine colleagues. She's married with a son and a daughter.
Okay, can everybody hear me okay?
So,
all right, well, welcome to the webinar, and this is my first webinar, so I'm a little bit nervous, so I want to thank everybody for
mic now and video
time out of their day. Pardon? You can't? do you want me to have myself or just? Okay, well, I was hoping I wouldn't have to share my picture until after. I'm going to move it over on my screen here if I can. Oops. That's okay. All right. Can everybody see okay and stuff? Okay. So yes, thank you for joining the webinar. I'm in my kitchen, so hopefully I won't have to move to a room to plug in my computer. So when Temi asked me to talk about gestational diabetes prevention and management, when I was going through a fair bit of the reading, there's really sort of not too much we can do to prevent gestational diabetes from occurring, and we'll kind of go through that. But there's lots of things we can modify for some of the risk factors, hopefully, that do cause gestational diabetes. So I do like to start my presentations with a case to work through. So we have a 38-year-old G3P2, and she's currently about 8 weeks gestational age. She just had a positive pregnancy test, then comes to her care provider. And she had a pregnancy about 10 years ago when she had a 9-pound male and did not have gestational diabetes in that pregnancy that she recalls. 2 years later, she had another pregnancy and did have gestational diabetes in that pregnancy, and that was diet controlled. And she did well in that pregnancy. It's been about, once again, 8 years since the last pregnancy, and so she's concerned about developing gestational diabetes again in this pregnancy. And she asks you, what are her risks, and is there anything that she can do to prevent gestational diabetes from occurring again? So the objectives for my talk today are to review the definition and the pathophysiology of gestational diabetes, review the risk factors, screening, and I'll briefly touch on treatment, and discuss the impact of gestational diabetes on the health of the mother and the child, discuss how we can potentially prevent gestational diabetes or reduce the impact. And then also, Temi wanted me to touch on the high and increasing rates of gestational diabetes among our First Nations women and ways to work with them to address their unique needs. I was very lucky in preparing for this presentation that the most recent Canadian Journal of Diabetes came out, and there's some really good research in there by one of our local researchers, Dr. Roland Dick, that does touch on our Saskatchewan population about risks and outcomes. So gestational diabetes is defined as glucose intolerance with onset or first recognition during pregnancy. So we know that there's lots of diseases in pregnancy that happen, and especially with hypertension in pregnancy, this is usually diagnosed after 20 weeks gestational age. But what is unique to gestational diabetes, again, is its first onset or recognition during pregnancy. So if somebody is 12 weeks gestational age and they get picked up with diabetes, it would still be considered gestational diabetes. And this comes into where you have that early screening to rule out overt diabetes, and we'll go over that in a little bit. So why does gestational diabetes occur? In a normal pregnancy, in early pregnancy, there's increased insulin sensitivity, and this is secondary to the hormones such as estrogen and progesterone, that blood sugars are actually a little bit lower in the non-diabetic but pregnant state. Later in pregnancy, after about 18 to 20 weeks gestational age, there's an increase in insulin resistance to facilitate placental transfer of glucose to the fetus for growth. So human placental lactogen is produced by the placenta, and this causes insulin resistance, which again, our goal is to provide nutrition to the fetus, and this facilitates that transfer. In women that develop gestational diabetes, there is beta cell dysfunction. So beta cells are in the pancreas, and they store and secrete insulin in response to a glucose load. The dysfunction occurs when the beta cells lose the ability to adequately sense blood glucose concentration or release sufficient insulin in response to the glucose load, and it can be exacerbated by insulin resistance. We know that in women that are overweight, that they will develop insulin resistance or decreased insulin sensitivity because fat cells have more insulin receptors, and then we have to overcome that at time. With tissue insulin resistance, this occurs when the cells no longer adequately respond to insulin. It's usually a failure of insulin signaling, and the rate of insulin-stimulated glucose uptake is reduced by about 54% in gestational diabetes compared to normal pregnancy. Now, I think pictures are usually worth 1,000 words, so I was able to come across an article that has some really great pictures to describe why gestational diabetes happens. So you'll see in this picture that in a normal pregnancy, prior to pregnancy, you have a normal sized pancreas. During pregnancy, the pancreas gets a little bit bigger because of beta cell hypertrophy, and that's to increase the insulin secretion to overcome the glucose load and overcome the peripheral insulin resistance. After pregnancy, everything normalizes, glucose goes back to normal, pancreas goes back to normal, and the insulin resistance normalizes as well. In women that have gestational diabetes, you can see that before they have a normal pancreas, however, they might have something underlying or predisposing them to develop diabetes in pregnancy. In pregnancy, that pancreas doesn't have that same hypertrophy of those beta cells. They're not going to produce as much insulin as someone that's able to overcome that insulin resistance. There's more glucose around, there's more insulin resistance, and again, I always tell my moms that develop gestational diabetes, it's truly nothing that they've done. It's that they've got a good placenta making lots of insulin resistant hormones, and they just don't have the ability to increase their own insulin secretion to overcome that insulin resistance. And then after pregnancy, we see that they might still have some impaired beta cell function, they might still have a little bit more glucose hanging around, and they still have that insulin resistance in the periphery. So we always talk about pregnancy being a stress test for life. Women that develop hypertension are at higher risk of cardiovascular disease. Women that develop gestational diabetes are at higher risk of developing diabetes in the future. And this was proven in a study in 2008 by Denise Faig that women that have gestational diabetes can develop type 2 diabetes, about 20% of them within 9 years of their pregnancy with gestational diabetes. And again, we know that this just signifies that there's something underlying that just puts them at risk in the future of that type 2 diabetes because there's that beta cell dysfunction. So risk factors for gestational diabetes include a previous history of a pregnancy with gestational diabetes, if they've had a history of polycystic ovarian syndrome or a history of acanthrosis nigricans. So that would be the darkening around the neck, under the armpits, or in the groin, and that signifies insulin resistance. If there's a family history of type 2 diabetes in the parent, brother, or sister. Ethnicity is a big risk factor, being in the African, Arab, Asian, Hispanic, Indigenous, or South Asian population. We tend to see this more frequently. Age greater than 35, women that are obese. If there's any past history of use of corticosteroids, so if these women have had a history of asthma that they've had to been on steroids for, or if they have any rheumatological diseases that they've been on steroids for, if they end up having an increased dose of steroids in their pregnancy, that would put them at risk of developing diabetes in pregnancy. Some women that come in with premature rupture of membranes or require betamethasone for any reason for fetal lung maturity, I usually recommend not testing for diabetes in pregnancy at the time that they get their steroids and for wait about a week after the steroid effect wears off, because it's going to cause insulin resistance from the steroids on top of the insulin resistance that's already there. Some of these individuals, it's good to check their blood sugars while they're on it, because you might pick up, especially if they're high risk ethnicity, of early development of diabetes in pregnancy. Another risk is delivery of a macrosomic infant. So in the study that was done by Dr. Dick that was just published in 2020, it showed that the strongest predictors of gestational diabetes and pre-gestational diabetes were increasing maternal age, if women have had a previous stillbirth or high birth weight infant and a previous history of gestational diabetes. He also found in his study that First Nations women in the oldest age group had an odds ratio for pre-gestational diabetes that was 10-fold higher than the non-First Nations women. And we'll go through some of those slides in a little bit. So if we go back to the case of the lady that we're chatting with, the risk of developing gestational diabetes in the literature is about 3 to 20% of women will develop gestational diabetes depending on the risk factors. So the higher number being in women that have more risk factors such as age or ethnicity. However, of interest is that the recurrence rate of gestational diabetes is about 30 to 84% in subsequent pregnancies. So when we go back to our patient, we kind of look at her risk factors. Her age is 38, so she's greater than that 35 cutoff. We don't know her weight just yet. We know that she's had a previous history of gestational diabetes and a large baby. We haven't figured out any family history. We don't know of her ethnicity just yet. But if she had a strong family history, if she's one of the higher risk ethnic populations, then her risk might be close to the 84% of the population. So for screening and diagnosis of gestational diabetes, this is taken from the 2018 Diabetes Canada guidelines. So screening in the first trimester should be considered for diagnosing overt diabetes in women who are at risk. So this would be a fasting plasma glucose or an A1C. And for those values, you have if a fasting glucose was greater than 7 or an A1C greater than 6.5%, then they would be diagnosed with overt diabetes. You could also use the typical 24 to 28 week gestational screening, and we have the 50 gram or the 75 gram. When you go through the literature, though, they do state that to apply the non-pregnancy fasting blood glucose or A1C criteria in early pregnancy may lead to an underdiagnosis of women with pre-existing diabetes. Again, because when we go back to the physiology of diabetes in pregnancy is that in the early pregnancy, because of the increased insulin sensitivity, blood sugars might actually be lower, so that's where you might miss those women that might have that pre-diabetes, but you should be able to screen those that have overt diabetes. When using the 24 to 28 week screening test, there is no validation that the criteria accepted for diagnosis of GDM in the second or third trimester are appropriate for use in the first trimester. So that gets a little bit tricky sometimes, especially if you're going to be using the 75 gram, because the values are a little bit different in the non-pregnant versus the pregnant state. There has been research looking at first trimester A1Cs and then combining a first trimester fasting blood glucose. So an elevated first trimester A1C of greater than 5.9% has a high specificity for predicting second trimester gestational diabetes. So it will kind of rule it in. If you combine a first trimester fasting blood glucose of 5.1 to 7 or an A1C of 5.7 to 6.4, it's more predictive of the need for medical management than when GDM is diagnosed in later pregnancy. So what I like to do with these women is that if I have somebody that I'm concerned about because of previous A1Cs or their risk factors, then adding on an A1C to their prenatal blood work and fasting glucose is an easy tool to sort of predict who you may need to go on and do a 75 gram, or you might just have them start checking their blood sugars in their pregnancy. If you do screen early and use a 75 gram glucose tolerance test and it is negative, it is recommended that you repeat it again at the 24 to 28 weeks. When you go through the screening through the CDA guidelines, again in Saskatchewan and in Canada, we do universal screening for all pregnant women between 24 and 28 weeks gestational age. If they have any risk factors, then it is recommended that we screen them earlier in their pregnancy. And you can use the two different approaches, being the 50 gram or the 75 gram. And I'll go through my preference, what I prefer, once I've gone through this. So the reason why we have these two approaches, if you've read through the guidelines, is that it's hard to come up with a consensus across Canada and across the world, actually. That's why I'm so fascinated by gestational diabetes, because if you go through the history of it, when it was diagnosed, kind of written about in the 1960s by O'Sullivan, it was mainly to predict women that are going to develop type 2 diabetes in the future. And then Priscilla White had come up with a classification system because they knew that there's complications with diabetes in pregnancy, as it does have maternal and fetal effects. And then there's the International Working Group of Diabetes in Pregnancy that have regular meetings and try to come up with different guidelines that we can apply universally. However, it's not happened as yet. So we recognize that there's the two different approaches, and the alternative approach is based on the International Association of Diabetes Pregnancy Study Group, and that's from the HAPO study, when they looked at the different quartiles of blood sugars, and the higher the blood sugars, the higher the risk of higher birth weight, operative deliveries, and C-peptides. And they used odds ratios of 1.75 and 2. And so that's where they came up with that 75 gram with the tighter targets. Once again, in Canada, we recognize that there are the differences. And in order to appease everybody, we've come up with this preferred and then the alternative approach. So the preferred approach, as you all know, is they have a 50-gram challenge, which is non-fasting. And I want to highlight that it's a non-fasting 1-hour test. If their 1-hour test is less than 7.8, they are normal. They do not have gestational diabetes. If you screen them early with the 50 gram and it's negative, you can reassess at the 24 to 28 weeks. If their value is between 7.8 to 11, then you'd want to go on and do the 75 gram glucose tolerance test. And that is if they have a fasting greater than 5.3, or a 1-hour greater than 10.6, or a 2-hour greater than 9. If they have one of those criteria, then they get diagnosed with gestational diabetes. If on their 50-gram test they have a value of greater than 11.1, they have a diagnosis of gestational diabetes and no further testing needs to be done. What we sometimes see coming across in our diabetes and pregnancy clinic are that women have a 50-gram screen that is done and it might be 12. Then they go on and have a 2-hour test, 75 gram, which does not need to be done. It's an unnecessary test for these women to have. So just remember, if it's greater than 11.1, you have your diagnosis. You do not have to go on and do the 75 gram test. If you do choose to do the alternative approach, you'll see that the numbers are a little bit tighter than on the preferred approach. So if I go back, you'll see it was 5.1, 10.6, and 9. On the alternative approach, it's 5.1, 1 hour greater than 10, and a 2-hour greater than 8.5. And again, this would be not even going for 50 gram, you go straight to the 75 gram. This one is a fasting test. Remember, if you're going to order it, to use this criteria on it, and don't use the other criteria because you are using the alternative approach. And again, if they have one value that is met or exceeded, they get diagnosed with gestational diabetes. So the alternative approach has led to a diagnosis of more gestational diabetes. However, there's been an inconsistent impact on the perinatal outcomes. And this is again why in Canada we have the two approaches. So when they've looked at the alternative approach, it has picked up about 30% more gestational diabetics, but we haven't found any change in the impact from our treatment. We haven't seen any lower large for gestational age babes or anything else like that. So this is again why we have the two methods. So I would use the alternative approach in some individuals if they've had a history of gestational diabetes in the past, say their A1C wasn't too bad when they were tested postpartum, and I want to screen them early in pregnancy. So instead of making them go for the two tests, I might just go ahead and screen them with the alternative approach. If I have a G1, P0 with no other risk factors, slim, everything else, I will do the preferred approach. But again, I kind of use my patient population about who I'm going to do the alternative approach on. So again, you have two options, and you can pick the one that you think is going to get you a little bit more bang for your buck. The other thing is these tests aren't pleasant for women to do. They are a 2-hour test. They are fasting. If you've had the 50 gram and you have to go for the 75 gram, it's not going to taste any better. So again, if you have somebody that's had a previous history or have multiple risk factors that you're quite concerned about, then you can go straight to the 75 gram test. So we go back to our patient, and things that I would ask her are that was she screened postpartum after her last pregnancy with gestational diabetes? If she had been screened and it was negative, has she been rescreened at any time for diabetes? If so, I'd go back and look at her test results and try to trend anything that was there. And this would help me pick up if she had any history of any underlying impaired glucose tolerance or impaired fasting glucose. One of the other things I would ask her, it's been 8 years since her last pregnancy, what has her weight been? Has she been gaining weight every year? Between her two other pregnancies, did she have an increased weight gain as well? What is her BMI? So we go back to our patient. She was tested postpartum. She's one of those lucky ones that had the 75 gram non-pregnant postpartum glucose tolerance test. So again, in this one, it's just a fasting and a 2-hour test. So again, that's how it differs from our pregnancy one, because our pregnancy one, we have a fasting 1 and 2 hour, and in the non-pregnant population, it's a straight 75-gram test. She did have some blood work done 2 years ago, and her A1C was 5.8%, which to me raises a bit of a red flag because it's higher than I'd sort of think. And then what if her A1C was actually 4.4% 2 years ago? Then what would I do? So for this patient, I would actually start with early screening. She's got enough red flags with her age, her previous history of gestational diabetes, previous history of macrosomic infant, that say that she came from Indigenous population and had a very strong family history of type 2 diabetes, then I know that she's kind of hit all of my risk factors, and I would definitely do early screening. I would probably do an A1C and a fasting glucose with her on her prenatal blood work. If she did have the A1C of that 4.4%, then I might actually say, let's just do a 75-gram glucose tolerance test, because then I can maybe pick up more, because then you'll be able to pick up the impaired fasting glucose or impaired glucose tolerance. Because I know she's got enough risk factors and her A1C was higher than I'd anticipate a few years ago, that's why I would do an A1C and a fasting glucose on her. So how do we manage our patients in pregnancy? So again, when they are diagnosed with gestational diabetes, we do usually have them meet with a dietitian and go through their diet and make some changes that they can, as well as talk about exercise and having them starting to check blood sugars. One thing I feel that I don't do a very good job with, but I'm sure my dietitians do a much better job of, are discussion of weight gain in pregnancy. So if women are overweight, they don't need to gain as much food. Talking a bit more about nutrition. Again, ideally, all these things should be done pre-conception for everybody. So I always say, when I'm teaching my residents, is that every visit with a patient that's of childbearing age should be a pre-conception visit. Talking about contraception, if they're overweight, getting into some weight issues, asking about their nutrition. Other management in pregnancy would be pharmacological. When you go through the Health Canada information, they do note that women of childbearing age are heavier now than in the past. 1/3 of women entering pregnancy have a BMI of greater than 25, and women with a higher BMI are more likely to have poor health and poor pregnancy outcomes, more likely to develop gestational diabetes, and also have large for gestational age babies. So I did get this off the Health Canada website, and I always think it's a good reminder for myself for plotting patients' weights. We have lots of people that come in and ask about their weight gain. I find sometimes when we're in our diabetes and pregnancy clinic, we're so focused on the blood sugars. We do, especially in today's virtual world, we're not measuring their weight as much, so I don't tend to ask about their weight as much. If you have women, though, that have a BMI of greater than 30, then the weight gain that's recommended is 5 to 9 kilograms. So this would be something to print off and provide them with to plot their weight through their pregnancy to help them realize how much they're supposed to be gaining, and so that they don't go above that if possible. Again, our dietitians do a great job about counseling about their healthy eating and also activity. I sometimes find that we don't emphasize activity as much as we could. Lots of times when women come into pregnancy, they do talk about eating for two. However, when women that are pregnant only need a modest increase in their calories and a greater increase in vitamin and mineral intake. The Canadian Food Guide actually suggests only adding in 2 to 3 Food Guide extra servings to their total number. So this might be an extra glass of milk and an apple or an extra piece of toast. And they also recommend having programs for nutritionally at-risk pregnant women. So in the city in Saskatoon here, we do have the Healthy Mother, Healthy Baby program, which supports women that are at risk for healthy food choices. And I think this is, again, one of those public health measures that we have to have affordable, healthy food choices for women of lower socioeconomic status, as well as women that live in remote areas that don't have the same access to healthy food options as we do in a tertiary or an urban center. When you look at the cost of food for an apple versus a chocolate bar, it's quite striking, and pop versus milk. So if we put public health measures in place so that we are able to have healthy food affordable for people, that is one step in preventing diabetes. All women who are at risk or diagnosed with gestational diabetes should be assessed and counseled and followed up by a registered dietitian where possible. Again, this is one of those other public health measures to have these dietitians available for individuals, that their wait time is not 6 months to a year, that they don't have to pay out of pocket to see dietitians. Right now, there's so much obesity and so many other medical issues that our dietitians are taken up with multiple other things versus being available for some preconception counseling for some of our individuals. As per the CDA guidelines, when meal planning, it should emphasize healthy diet with a minimum of 175 grams of carbs distributed over 3 moderate-sized meals and 2 snacks. Once again, is replacing higher GI food index with lower glycemic index foods. In our diabetes and pregnancy clinic, I have lots of women that come through and say, well, before they were pregnant, they never ate 175 grams of carbs per day, and so eating that much makes them feel unwell. Usually what I do is, if it really makes them feel unwell, then I just recommend that they try again, just eat healthy, and then I'll have them in touch with their dietitians who can also help them out. And I think if people actually go through the number of grams of carbs they eat per day, they'd probably be a little bit surprised of how much they actually eat versus how much they think that they eat. Activity is very important, and I was really happy that the SOGC came out with the exercise and pregnancy guidelines recently, and a couple of years ago as well. And prenatal physical activity can actually reduce the risk of gestational diabetes by 38%. So again, encouraging physical activity amongst women for preconception counseling as well. One of my colleagues out in BC feels that we should remove the pregnant or expecting mother signs and put them at the end of the parking lot so that we encourage exercise in our moms that are going to the store so they don't get to park too close, which I thought was a pretty entertaining idea. The goal is 150 minutes per week of exercise, and there should be a variety of aerobic and resistance exercises. A lot of women with the physiological changes that happen get sore hips, sore back, so it's hard to exercise, but even a walk around the block to start off with. And I always encourage my moms to take that time for themselves. Even if it's just a 10-minute walk after supper and your partner can look after your other children, that's great. So you can work your way up to more exercise during the week, starting with 15 minutes and work towards 30, 3 to 4 times a week. In a study that was done in British Sports Medicine, 51% of women indicated that the benefits of physical activity in pregnancy outweighed the costs, and 68% agreed that it was feasible. This is, again, one of those other public health measures as well, is that for women to exercise, sometimes you have to go to the gym, especially in Saskatchewan when it's cold in the winter and icy. They don't want to take the risk of falling and hurting themselves while being pregnant. So if we have options where they can walk, like I know the Fieldhouse and the Shaw Centre are options where they can walk, but again, there's always a cost indicated with that. So if there's some public health measures that, especially with people of lower socioeconomic status, that we provide some way for them to get the benefits of exercise and also the time it takes to fit in exercise as well. I always say we give our women aspirin to prevent hypertension, yet we're not very good at recommending exercise to prevent hypertension or diabetes. The glycemic targets in pregnancy are less than in the non-pregnant state, so the fasting glycemic targets are less than 5.3, 1 hour after meals less than 7.8, and 2 hours is less than 6.7, which you all know about. Pharmacological measures for treatment of diabetes in pregnancy include metformin and insulin. In the new guidelines, glyburide is now a third-line agent. We have been using a fair bit more metformin in pregnancy in our patients. There was a study that came out of Toronto called the Metformin First study that found that women were diagnosed with gestational diabetes that were started on metformin and insulin was added later on tended to have a little bit better glycemic control. I tend to use my metformin if their fasting blood sugars are 5.3 to 6, or their 1 hours are 7.8 to 8.5, or the 2 hours are 6.7 to 7.5. I think metformin might be beneficial. If I have any fasting blood sugars greater than 6 or 1 hour is greater than 8.5s or 10s, then I go straight to insulin. However, I will sometimes add metformin in because metformin is a medication that works by decreasing improving insulin resistance, and it kind of counteracts the insulin resistance caused by the pregnancy. So there has been evidence that adding metformin to insulin can decrease insulin requirements, and so it's an option for women that are not wanting to take insulin right away. I also find if their blood sugars are close to target, I sometimes worry about starting a bit of insulin because I don't want to cause any lows, and this just lets me bridge a little bit before I decide to start insulin. Some of our women do fine on metformin alone. Some of our women, we do have to add insulin. Some women that are on insulin, we add some metformin to decrease the amount of insulin that is required. So if we go back to our patient, on her blood work that we did, her A1C is 6%, so again, it's greater than that 5.9%, and her fasting glucose is 6.1. So again, this already puts her at a higher glycemic target than our less than 5.3 that we want. So what do I want to do with her? I don't want to do any further testing. I just want her to start checking is what I want her to do. So I would provide her with a meter. She's got enough risk factors that I think she's actually got something underlying. I would make a referral to the dietitian. I would counsel her about the targets in pregnancy, again, the ones we already discussed. I review her activity level and recommend some activity if we can. The other thing I counsel women is the normal physiology of pregnancy. We know that our targets are a little bit up right now. They're not terrible. We'll see what we can do with some dietary interventions and some exercise. But also saying in this initial part of pregnancy, she's only probably 9 weeks now, is that her blood sugars are going to be a little bit better because of increased insulin sensitivity. And when she hits that 18 to 20 week mark, and we know that insulin resistance kicks in, then those blood sugars are going to go up. And so it's better to be on top of that and checking early so that we can intervene early as needed. The other thing I chat about with women as well is the postpartum screening, and really strongly recommend postpartum screening be done. Again, for her, she's got enough risk factors. She's a little bit up. I might just tell her postpartum that we're just going to check her blood sugars after. In most of our women with gestational diabetes, we do stop checking blood sugars after delivery, after about 24 hours. But for these women that I'm a little bit more concerned about, then I'll suggest that maybe they just continue checking postpartum as well. The other thing we talk about is the impact of gestational diabetes in pregnancy on the mother and the fetus. So the risks to the mother are that they are at higher risk of developing hypertension in pregnancy. There is an increased risk of an operative delivery, such as a C-section or forceps delivery, because of the macrosomia. So once again, insulin does not cross the placenta, but the glucose does, and this facilitates growth of a fetus, and hence the macrosomia. In these women, as we discussed earlier, there's the increased risk of developing type 2 diabetes, as well as there's going to be an earlier delivery. I normally don't counsel women about when to deliver because that's not my job, that's up to the obstetrician. But if they do have bigger babies, they might deliver before they're 38 weeks. Usually it's recommended delivery between 38 to 39 weeks if they're on insulin. But if they've got a macrosomic baby or polyhydramnios, they might end up delivering earlier than that. The risks to the fetus are, again, large for gestational age. Once again, that glucose passes through the placenta, provides fuel for the fetus. The fetus will increase its insulin production to deal with the glucose coming across. Insulin causes weight gain, therefore you get a large baby. There's also the risk of hypoglycemia when the baby is born, because they'll have lots of insulin on board, and once you cut that umbilical cord, their glucose supply is low, but they still have lots of insulin on board, and then they'll develop a low blood sugar. There's also the risk of jaundice, because they'll increase their red blood cell production to carry oxygen because of the hyperglycemia, and then when they're born, they will be breaking down the red blood cells causing jaundice. Again, there's the shoulder dystocia that can occur, potential shoulder injuries. When they're a bit older, there's an increased risk of obesity and, again, prematurity. There's also an increased risk of stillbirth as well. We don't tend to see it as much in the gestational diabetics, but the odds ratio from Dr. Dick's study that came through is that the risk of stillbirth is higher in women, and especially First Nations women with gestational diabetes, compared to non-diabetic pregnancies. The long-term maternal and child risk, kind of what we talked about earlier, the increased risk of underlying impaired glucose tolerance, the metabolic syndrome and risk of cardiovascular disease. Again, we know that they kind of all run together. Diabetes, high cholesterol, hypertension, that all puts them at risk, the long-term risk of cardiovascular disease. In the child, again, there's the increased risk of childhood obesity, that intrauterine fetal programming predisposes them for obesity, as well as there's their increased risk of developing type 2 diabetes as well in the future. And again, this is another public health measure in that we are seeing more childhood obesity, and we should be screening these children probably a bit earlier on. Again, I'm not a pediatrician, but we just know if they have come from a mom with diabetes in pregnancy and are obese, then earlier screening is recommended. So among our First Nations populations, we know that the rate of gestational diabetes is higher compared to the non-First Nations in Saskatchewan, and it is increasing quite a bit. There's been a 6-fold increase in the gestational diabetes incidence in First Nations and non-First Nations over time. These are some of the charts from Dr. Dick's study. I try to bring my green arrow down, but it's not working very well. That show, if you look at the graph A for gestational diabetes from the 1980s to 2010, that the rates are increasing in First Nations and non-First Nations, with a higher increase in the First Nations population. We also see a higher increase in pre-gestational diabetes, especially higher in the First Nations and the non-First Nations. And when we look at all diabetes in pregnancy, you can see how the graph diverges quite significantly with a higher rate in our First Nations population. And again, it is felt it's from colonization as well, and just their the increase over time in the intrauterine fetal programming as well. When you look at age-specific incidence of gestational diabetes and pre-gestational diabetes is again one of the risk factors for developing gestational diabetes was age greater than 35, and we can kind of see the rates increase with increasing age. In the First Nations population, it increases until about age 35 and then it drops. But if you go to the second graph on B, you'll see that there's an increase in pre-gestational diabetes in that age group, which means that they're developing pre-gestational diabetes, so that's why the rate of gestational diabetes drops off in these individuals. So the divergence of age and decrease in gestational diabetes, once again, was in those that were 35 plus and were more likely explained by the transition to pre-gestational diabetes being most likely type 2 diabetes. So how do we improve outcomes in our women? So I think we can do earlier screening and diagnosis, again, really going through your risk factors on your patients. Are they overweight? Are they of a high-risk population? Is there a strong family history of type 2 diabetes? If so, screen early on your first prenatal blood work. Having that multidisciplinary approach, again, if we could have people see dietitians beforehand, preconception, that would be great. Again, more community-wide awareness, which is what this presentation is for, more community-driven education initiatives. We do have universal screening, which is great. However, it's making sure that those people do get screened, making sure that they do get the prenatal care so we can do that testing. The other one is the resources to healthy food choices. Again, a public health measure that we have to have healthy food choices available to those in remote areas as well as those of lower socioeconomic status. And I think the bigger one is from women from the First Nations population, from the literature out there, is having increased cultural support from the community elders and support for the young families for these individuals as well. Breastfeeding is strongly recommended immediately after delivery and for at least 4 months postpartum. It does have benefits of reducing neonatal hypoglycemia, offspring obesity, and could prevent metabolic syndrome and type 2 diabetes in the mother. We know that breastfeeding is kind of a great form of exercise that you do while sitting down while postpartum, which is great. It helps with weight loss. However, I also am quite cognizant of maternal mental health as well, and breastfeeding is not the easiest thing to do, so it's strongly encouraged, but if it's not working, then I understand that, and I don't pressure them to breastfeed, but strongly encouraged, again, because of the benefits with it. But again, maternal mental health is also very important. So for postpartum screening and interventions, Diabetes Canada does recommend screening between 6 weeks and 6 months postpartum with a 75-gram glucose tolerance test. Across Canada, the uptake of postpartum screening is quite low, and we did a study numerous years ago, and the uptake is about 21% or less in Saskatchewan, which means we're not doing a very good job of postpartum screening. I see that Dr. Silkenstone is joining, and she's got a project looking at kind of risk factors for postpartum infections, and she did send me an article about early postpartum screening, such on day 2. And there is evidence that postpartum screening on day 2 with a 75-gram test is as effective as detecting impaired glucose tolerances doing it 6 weeks. So if you have a patient that you think is going to be high risk for developing diabetes in the future, or impaired glucose tolerance, but they're also high risk of not coming back for any postpartum screening, then it's okay to screen them a bit earlier. I wouldn't recommend doing an A1C on these individuals, just because if we do have good glycemic control in a pregnancy, then their A1C should ideally be okay, and then you might miss an underlying impaired glucose tolerance. So that's where the 75-gram for that postpartum screening would be beneficial. The NICE guidelines from the UK actually recommend doing a fasting plasma glucose between 6 to 13 weeks postpartum, or an A1C after 13 weeks postpartum if fasting is not available. And that's again because they actually don't even recommend the 2-hour test. I think because it's a 2-hour test and it's hard to have people come back, especially if you have a 6-week-old baby. Do you really want to sit there for 2 hours and be screened? So in some of my individuals, I will send them home with an A1C and a fasting glucose to be done 3 months postpartum. And another thing that we could do is have a postpartum record for these individuals. We do have prenatal records. Dr. Graham Smith in Kingston has a really great postpartum record for his individuals, because he knows that when individuals have hypertension in pregnancy, are at high risk of cardiovascular disease. And so about 6 months postpartum, they recommend glucose testing as well as cholesterol testing to pick up these women. So I always think that we do such a great job of having these ladies come back with their babies for immunizations. Let's not forget about the mums when the babes come back for the immunizations, and chat with the mums. Did they have diabetes? Did they get checked? Here's a lab rec, get checked. So there's lots of ways that we can intervene, and remembering to focus on mom as much as we focus on the baby as well. So in the unique needs of our Indigenous population, there is an intra- and intergenerational diabetogenic role of gestational diabetes in this population. So the focus should be on primary prevention initiatives before and during the reproductive years. So again, every appointment is a preconception appointment. Programs to prevent gestational diabetes. Once again, I don't always think we can prevent them because some of the risk factors are non-modifiable. But the modifiable ones, such as weight and activity, are things that we can intervene on. And ensure universal screening, again, making sure that these women do get some prenatal care, that they have access to care providers that are able to emphasize the importance of the screening. And again, optimizing the management, so going over the targets, talking about treatment options, making sure that they have local resources available, such as dietitians and diabetic educators. In today's world of virtual care, it's actually been really nice in the sense that we as physicians can phone our patients, but we can also utilize their local diabetic educators and dietitians to help us out a fair bit. And then it's somebody in their community that understands them, that knows them, and it's really quite helpful. And I think we also need to provide initiatives for women for postpartum screening to reduce the rates of type 2 diabetes in them, and as well as their offspring. So again, really emphasizing that postpartum glucose tolerance test, the importance of it. If it's really hard for them to come back for a 2-hour test, there are some other options that we can consider. The CDA guidelines, again, would recommend the 2-hour test just because it's more sensitive and specific. But if that's going to impair somebody coming back for a test, then you do have another option with an A1C and a fasting glucose as well. So if we go back to our case, she did well in her pregnancy. She started testing once she received her A1C In the ideal world, she met with her dietitian. She was on some insulin in pregnancy, and then postpartum she discontinued the insulin, but she continued to check her blood sugars as we recommended. She noticed that her fasting blood sugars were 7 to 9, but during the rest of the day she was actually pretty good. We went on and did a 6-week 75-gram glucose tolerance test, and it did show that she had type 2 diabetes, and she started on metformin. And then with regular checkups, she adopted a healthy lifestyle for herself and family. So that's my dream patient in my dream world. But again, I always say for my moms that have gestational diabetes that this is the time to make those changes that are needed. I just saw a lady yesterday in clinic that had gestational diabetes, and it has gone away. She's not gone for postpartum testing yet, but she's going to go. But she was asking about her risk of developing type 2 diabetes, things that she can do to prevent this, which I thought was really great that I was able to have that conversation with her, because I don't always get that chance to have that conversation with her. So if there's other care providers out there that are able to do that, even lactation consultants, etc., that would be great. So in summary, I don't think gestational diabetes is preventable due to the non-modifiable risk factors. I think we can work on increasing awareness and modifying the risk factors, encouraging healthy eating, exercise, something I always say to my patients, something that we should all be doing, early screening, but also postpartum screening, and then cultural recognition and accessibility to resources that can help. These are my references, and I'm open to any questions. I see Megan's had lots of great things to say about the Saskatchewan Prevention app and the Healthy Weight Gain booklet. And then one of the questions was, is there a role for diabetes educators for women with gestational diabetes, as understanding the numbers and monitoring might be confusing? Yeah, so in our group of individuals, when they get diagnosed with gestational diabetes, they do touch base with actually a dietitian first. And the dietitian provides them with our targets as well as monitoring and going through their diet. If there's in other sites that you don't have a dietitian available and that person's seen with a diabetic educator, that's great because they can review those things as well. And you're right, the numbers are confusing. And in my individuals that have gestational diabetes, that are pre-existing diabetics postpartum, then I always have to reinforce that after they deliver, they don't have to try to achieve the same glycemic targets. And then even our women with gestational diabetes, for the most part, their blood sugars come right back down after they deliver. Again, unless they're one of those that their A1C that we do in pregnancy is at 8. And I'm like, oh, I'm a little bit more concerned about you, and I think you probably have underlying diabetes. So that's why I really like having an A1C done sometimes on these individuals. And sometimes when they go for their glucose tolerance test and they get diagnosed with gestational diabetes, I will sometimes not choose wisely, and I will send them for some more blood work to check an A1C, especially if I think that based on their values from their glucose tolerance test that they might have something underlying. And once again, if it's really checked at 24 to 28 weeks and they have an I or A1C, then you're likely seeing that this has been going on longer than we think, that 24-week time. And then why is the risk of stillbirth higher in diabetes and pregnancy? So it's usually in those that have pre-gestational diabetes, such as type 1s and type 2s. And then also with the gestational diabetics, especially if their glycemic control is not good. And we don't really know what causes the stillbirth at this point in time. It's felt that is the baby having some lows? Do they have lots of insulin on board? Is there some other metabolic effect going on or electrolyte abnormalities that can happen? In my type 1s, I worry a fair bit about it. If they're having decreasing insulin requirements, is there something going on with the placenta? Again, maybe it's a macrosomia and a uterine placental mismatch or a fetal placental mismatch that's occurring, some hypoxia or anything else like that. And this is why fetal surveillance in these individuals is so important as well. But when you talk to the MFMs about the fetal surveillance, it's looking for hypoxemia. It's not looking for anything else. It looks for the large babies. And sometimes that's why they end up delivering early, is because of the macrosomia as well. One of the other questions is, do you find a majority of physicians are doing GDM testing in the first trimester? I think it depends on kind of the patient's risk factors and if they get tested earlier. So I know that the colleagues that I work with, being maternal fetal medicine, is that if somebody's had previous history of gestational diabetes, they'll send them for an early glucose tolerance test. And I don't really know too much what might happen up north for some individuals. I don't know if there's, if the nurse practitioners are doing most of their early blood work, but to add on an A1C and a fasting glucose is okay. The CDA did come out with pandemic guidelines just because of sitting in a lab for 2 hours is a bit risky. So that's where they kind of recommended you can do an A1C and a fasting glucose earlier on. And again, if it's greater than 7 or the A1C is greater than 5.9, then you can diagnose gestational diabetes. So once again, the majority would be doing the GDM testing earlier if there's risk factors as per the guidelines. One of the other questions is, should First Nations women automatically be considered a risk to screen in the first trimester? I would look at the other risk factors they have. So ethnicity is definitely one. If they are G1, P0, not overweight, if not a significant family history, then potentially no. But if they are overweight and mom has type 2 diabetes and they are actually they came from a gestational diabetic pregnancy, then I think that yes, screening the first trimester is easy to do. About the pandemic increasing pre-GDM or GDM, I don't think we could see anything just like that because it's only been 6 months so far. It's actually quite interesting because I was just reading something on the news at lunch when my kids were home about new guidelines for screen time for adults and activity because of the pandemic and the more sedentary lifestyle. So maybe we'll see in the next year or two if we'll see an increase in GDM or not. And then would I be more strict with glucose targets in the first half of pregnancy when you don't want a large for gestational age weight gain versus the second half? Tough question, because we try to use the targets. It's kind of interesting because in the CDA guidelines, they do talk about using abdominal circumference to kind of target treatments a little bit. So if they have an abdominal circumference greater than 75th percentile, then having tighter targets versus if their abdominal circumference is less than the 75th percentile. So it's not made it into any mainstream practice, but the number needed to treat was about 10 or 11. So who knows, maybe in the next couple of years, if somebody has had a stillbirth, despite having some good glycemic targets, then I sometimes will try to target a little bit tighter blood sugars. I do look at the size of the baby because I do, if patients have a small baby despite having, I know blood sugars are slightly above target, then I tell them not to worry as much because we sometimes see that their fastings might be 5.6, but they've got a babe on the 50th percentile, and I'm not going to start treatment right away. I'm not going to tighten up my targets. I might be a little bit more lax. If they do have a larger baby, I try make sure that they're more often within target than not. And it's especially difficult in that first half of pregnancy because we know that there's that increased insulin sensitivity, and then the insulin resistance doesn't really kick in until that 18 to 20 week time. So I don't want them to have lows either in that early part. So kind of just watch and then might get a little bit more tighter later on. You all had very great questions, and I appreciate you taking the time to join. And my talk went right a little bit longer than I thought, but I do appreciate everybody coming. And I have 2 emails. One is at jill.newstangel@usask, and the other one's jill.newstangel@Sask Health Authority. So please feel free to email if you have any questions.
Okay, thank you very much, Dr. Newstead Angel. That was a great presentation, and thanks for everyone for your participation and for your excellent questions. I think that's about it. We'll send out a feedback survey about this webinar, and please feel free to respond. Also, we have an upcoming webinar next month, November 19, about opioid use in pregnancy and neonatal abstinence syndrome. So if you're interested in that, please also register the same way you registered for this webinar. I think with that, we've come to the end of this webinar. Thank you so much for your attendance. We'll have the link to the webinar also posted on our website. The recording will be available, so feel free to share that as well. Thank you very much.
Thank you, everybody. Once again, have a great rest of your day.
Yeah, thank you.